Okay, hello everyone. Let's get started. Let me bring up my slides. Let's go back to the start. All right. Okay, so hello everyone. My name is Simran and I'll be going over the pharmacology of drugs used to treat constipation, diarrhea, and IBS. Now, I'd just like to acknowledge and say that the content of this lecture is largely courtesy of a former faculty member, Dr. Greg Sawyer, and I have modified and updated the slides as necessary. Okay, so I'm more than happy to answer any questions via email, or if you want to post it on Canvas, I'll look up in the discussion forum. Otherwise, please feel free to email me and I'll try to get back to you. Okay, let's just activate this pen. Awesome. All right, let's get started. Okay, so here are your learning objectives for this lecture. Now, as you can see on the slide, there is a lot to take in, but don't stress. It's possibly beneficial that this is a recording, as you can stop and start and go back to sections as required. Okay, so my job today is to briefly explain initially the physiology of the ENS, or the enteric nervous system, and then describe the pharmacology of each of these groupings of drugs I have listed over here. And then later on next week, you will have the wonderful Dr. Joyner, who will come and reinforce some of these pharmacological aspects, obviously with a specific therapeutic twist, so how these drugs are used therapeutically. Okay. So let's get started. Like I said, we will start off by discussing the enteric nervous system. The enteric nervous system, which I have abbreviated to ENS in most of the slides. So this is the most important regulator of gut function. And then when I mention or talk about the gut, we're talking all the way from the top of your esophagus all the way to the bottom of the end of the gastrointestinal system, which is the anus. Now, as shown in the diagram on the slide, excuse me, the ENS is part of the autonomic nervous system. There you go, my circling's not that great. And as you know, the autonomic nervous system is made up of the sympathetic and parasympathetic. Now, it is important to remember that the ENS, or the enteric nervous system on its own, does not rely on, so it doesn't actually need the sympathetic or parasympathetic system to tell it what to do. The enteric nervous system kind of functions on its own. Okay, and some say, or if you look in the literature, you will see that the ENS is sometimes referred to as the second brain of the body, and that's because, like I said, it can function pretty much by itself without any input from either the sympathetic or parasympathetic. Now, saying that, as you can see, the ENS does receive innervation or input from both of these systems, and when you get increased parasympathetic input to the ENS, this results in increased ENS function, which consists of increased contraction and increased secretion. So when we talk about contraction in today's lecture, we will mostly be focusing on gastrointestinal motility. Okay. Now, in comparison, when we get input or increased input from the sympathetic nervous system, what this does in the enteric nervous system is to actually decrease contraction and secretion, right? And I'll leave it to you to think about why this happens, so the increase and decrease from those two nervous systems. All right, next slide. Okay, so let's dive a bit deeper into the enteric nervous system. So here is a description, and then on the next slide we have a diagram, and I will go over the diagram as well. Okay, so if we dive a bit deeper, okay, as noted on the slides, the enteric nervous system is made up of the myenteric plexus, abbreviated as MP on the slides, and the submucosal plexus, abbreviated as SMP in the slides. And like I said, on the next slide, I will go over a diagram. And this has some other names which are commonly used to describe these layers. But the myenteric plexus and the submucosal plexus are the most common names used to describe these areas. Okay, and remember what the word plexus means. It means simply a collection of neurons. Okay, and so as you will know, the myenteric and submucosal plexus have distinct locations as well as functions. And that is why we're going to, it's important to discuss the physiology briefly, because this will help you to understand the pharmacology later on. So the myenteric plexus regulates both contraction and relaxation of the longitudinal circular smooth muscle. Okay, whereas where was I? I forgot my train of thought. All right, here we are. So the submucosal. So we say the myenteric plexus regulates the contraction and relaxation of the longitudinal and circular smooth muscles. Whereas the SMP, or the submucosal plexus, this regulates more the secretions, the absorption from the gastrointestinal epithelium. And this plays a role also in local blood flow and as well as neuroimmune activities. So what gets into the GI tract, what leaves the GI tract. Okay. And lastly on this slide, you will note that there are multiple neurotransmitters involved in enteric nervous system activity. So we can't talk about pharmacology, or we can't have a nervous system, right, without some kind of signaling molecules kind of controlling all of this contraction and secretion. So the major neurotransmitters, as noted on the slide, are acetylcholine, serotonin, dopamine, norepinephrine, and nitric oxide. And the drugs that we talk about later in the slide interact with the receptors where these endogenous neurotransmitters bind. Okay, so as promised, these figures show a diagrammatic view of what I discussed in the previous slides. And I'd like to reinforce that the enteric nervous system is found within the walls of the gastrointestinal tract. So, and further, you will note the arrangement and distribution of the myenteric plexus and the submucosal plexus. Now remember, I said it's not just what they do, so not just their function, but also where they are placed. Okay. So remember, I said the myenteric plexus is more involved in both the contraction and elongation of the circular smooth muscle as well as the longitudinal smooth muscle, right? Now think about this with respect to gastrointestinal motility, right? How does this happen, right? So if you can think about circular smooth muscle, right? When this contracts, what happens? It becomes smaller, right? So what do you think if you can think of this as your intestine and you're contracting it, so you're making it smaller, what's happening? It's pushing, you're hoping it's going to push whatever is in the intestine through, right? Similarly, the longitudinal smooth muscle, which can be thought of, or very basically thought of as a square, which is not a square, but you can think of it as that. When this contracts, it actually becomes smaller, right? So you have the myenteric plexus both controlling the contraction of the smooth muscle as well as the longitudinal muscle. So the contraction and relaxation is what is enabling that motility. So it is enabling food or water, or we often refer to it as a bolus, to move along your GI tract, so your intestine and into the colon. Okay, so you can see from the diagram on the right, the submucosal plexus, as its name suggests, is in the submucosa. Okay, so there we have the submucosal plexus, and it is just below or sub the mucosa over here. And in over here we have your lumen, right? This is where all your wonderful secretions from the submucosal plexus are going into. All right. We've made a mess of that diagram, haven't I? Okay, so I suppose, like I said, this slide was just to reinforce what some of the text here I described So just think when we talk about motility, gastrointestinal motility in coming slides, just think about or remember that we're controlling the myenteric plexus is controlling the contraction and relaxation of those circular and smooth muscles, which enables that bolus to move along. Okay, so peristalsis, it's I guess it's what I've mentioned, and one of the many functions. So this is not the only function of the enteric nervous system. Is, and we all do this. It happens in our body without us having to think about it. So remember, I said the ENS is part of the autonomic nervous system. So you don't need to think about having to move your food through your intestines, right? It just happens. So it's part of the autonomic nervous system. Now, like I said, think about the longitudinal and circular smooth muscles I described in the previous slide, and try and apply it to this diagram, right? Think about how the contraction occurs behind the bolus and how, and how the longitudinal muscles either shorten or contract to enable that bolus to move along. And then on the slide, we've got, I've mentioned two neurotransmitters. We've got acetylcholine, and nitric oxide. These control the contraction and relaxation of these muscles to enable that bolus to move along. All right. Okay. So what I've been talking about so far has mostly been what is, I suppose, normal or in normal physiological conditions. Now let's talk about, I suppose, when problems arise, right? So if you have constipation. And for the purposes of today, very simply, constipation can be defined as fewer than 3 bowel movements in a week. Okay. So, and like I said, my role today is to give you the information how the drugs work. And later in the week, I think it's Monday, Dr. Joyner will get into the therapeutics of this specific topic. Okay, so when we're talking about constipation, like I said, we're going to cover specific drugs or specific agents which have been grouped into these, I suppose, subgroupings. And the first subgrouping is referred to as prokinetic agents. Now already think about what we talked about, peristalsis, right? And what constipation is. And then think about this name, prokinetic. You already have an idea of the mechanism of action of some of these drugs. Okay, so like I said, as the name suggests, pro and kinetic, which could be loosely translated into promoting motion, right? That is exactly what these drugs do, which is to increase gut peristaltic activity. Now we'll cover drugs which fall into the 3 classes of dopamine receptor agonists, opioid receptor antagonist, dopamine receptor antagonist, and serotonin 5-HT4 specific agonists. Okay. Now there is a lot of information on this slide. You do not need to know everything which is on this slide, right? The most important thing that you need to know is the mechanism of action and the pharmacology, all right? So the first agent, which we will talk about, is metoclopramide, right? And here's a brand name. So when I talk about drugs in this lecture, I will describe the generic name. How good is my handwriting? Not good. So generic and then the brand name over here. All right. That's how I have done my slides. Okay. Now, while there are 3 receptors listed here, the main mechanism or route of action is through inhibiting or antagonizing the D2 receptor. Okay, so in normal physiological conditions, the release of dopamine slows down or decreases muscle contraction, and it does this by controlling the amount of acetylcholine released, right? Now, if you think back to a few slides ago, I said acetylcholine was one of those neurotransmitters which controls peristalsis. Okay. So what metoclopramide does is by blocking pre-junctional also sometimes presynaptic. So those are labeled over here, right? By blocking these presynaptic dopamine 2 receptors with metoclopramide results in an increase in acetylcholine release, right? And this results in an increase in digestive contractility, so an increase in peristaltic activity, right? So think about the minteric plexus and you're increasing the peristaltic activity there. Okay. Furthermore, some of you may have heard of metoclopramide. So if you look down here, some of you may have heard of this drug being used in the context of an anti-nausea or an antiemetic agent, right? Now, metoclopramide can cross the blood-brain barrier, and it can block D2 receptors in what is, some of you may have come across or know as the chemoreceptor trigger zone. And this is actually a pretty potent anti-nausea and antiemetic agent. And we'll talk about some of the side effects of this. Okay, so here we go, as promised. So like listed on the slide are therapeutic indications, and I will keep saying this, but Dr. Joyner will come and cover this with you in more detail. I'd like to focus on this box warning over here. Okay. As I mentioned in the previous slide, metoclopramide can cross the blood-brain barrier, and when it does this, it blocks central nervous system or dopamine D2 receptors in the brain. Okay. And what this can do is it can actually, result in a condition called tardive dyskinesia. And these are involuntary and often repetitive motions. So it could be like a ticking, or it could be like a, I'm not sure if you can see if my camera is coming. And these are involuntary, and these are caused by this antagonism. This is, like it says, it is irreversible, but it is very rare. So it's less than 1% of patients, but still, it's one of those warnings which is pretty serious. Okay, so this is one of the main reasons metoclopramide is only recommended for short-term use. Okay, there you go, very short-term use. Other adverse effects include Parkinsonian-like symptoms such as dystonias and akathisias. But the good news about these are likely to go away once the treatment is stopped and the drug is cleared from the body, right? The tardive dyskinesia is the one which is relatively serious because it can be irreversible. Okay. And then we've got some common adverse effects which you will note in this lecture are relatively common across drugs. Okay, so you're all experts in metoclopramide. Let's move on to opioid receptor antagonists. Okay, so let's try not to get our agonists and antagonists mixed up on the slide. Okay, let's start by discussing the fact that opioid agonists, okay, are used for the management of pain, and if you use opioid agonists for an extended period of time, what happens? You get constipation. Okay. So while the efficacy or analgesia is determined by the central or the opioid receptors in the brain or the central nervous system, opioid receptors exist in the enteric nervous system and the GI tract, and when you interact with them, or when drugs interact with them, you can result in decreased motility and therefore that constipation, right? So remember, we're talking about an agonist now, right? So these were used, like I said, for analgesia. Okay, so to counteract this, a class of drugs called peripherally acting mu-opioid receptor antagonists, abbreviated to PAMORA, was developed. And now, as the name suggests, these are antagonists, and these agents are designed to act peripherally, only peripherally. So hopefully they do not cross the blood-brain barrier, and they antagonize the effects at the mu-opioid receptor, preferably in the enteric nervous system, to combat that opioid analgesic medication induced constipation, right? So if someone is on long-term codeine or tramadol and it's giving them constipation, you could think about a Pamora to counteract the drug-induced constipation from the codeine or tramadol. Okay, so how do they work? So on the slide are Pamoras currently in use, right? So we've got methyl naltrexone, alipipaman. I'm not going to go through them, but like I said, I've listed the generic and then the trade name. Okay, so as mentioned, these drugs work by antagonizing peripheral, right? Peripheral. We're not going into the brain. These are outside. Mu-opioid receptors. So when they antagonize these peripheral receptors, this reduces or lessens the gastrointestinal adverse effects of things like tramadol codeine. So it reduces the constipation. Okay, and what I would like you to note is that these agents have specific chemical compounds or moieties added onto them, which make it difficult for them to cross the blood-brain barrier. Okay, so like methyl naltrexone, you've got this, right? Positively charged quaternary compound over here. Naloxegol, you've got this long chain added onto it, right? Similarly for naldomethine, you've got this compound over here, right? Now, the effect or what happens by adding these specific agents is we're adding these agents to prevent them either increasing its molecular weight or increasing the charge on it, or making it less likely or more likely actually to interact with the P-glycoprotein receptor. Now most of you, if you remember, the P-glycoprotein receptor is in the blood-brain barrier, and it's an efflux. It will actively kick drugs out or kick compounds out of stop them from entering the blood-brain barrier. So a lot of these moieties added on to these agents prevent them from entering the blood-brain barrier, so acting in the periphery. Okay, so where is my train of thought? Okay, so I'm just making sure I have told you everything I wanted to tell you on this slide. All right, so okay, let's cover each of these drugs. I think it's important to kind of know how and why. All right, so the methyl naltrexone. So you have probably heard of the word naltrexone or the drug naltrexone, or you will cover later on when you cover opioids, where it has this methyl added onto it. All right, and this makes it, like I said, it gives us this positive charge, and it gives it even I suppose more. It gives us quaternary charged amine, which is poorly absorbed from the GI tract, right? So like I was saying, things about not crossing the blood-brain barrier, this actually makes it stay in the GI tract for longer because it's poorly absorbed because of that positive charge. So it's actually perfect for what we want it for, which is for constipation. Okay, so the next drug, naloxegol, and some of you are probably thinking naloxone. Correct, it is a derivative of naloxone, and it has a long polyethylene glycol chain, right? So this box, which I have now boxed over and over again, is a polyethylene glycol chain, and we'll actually talk about this later on in the lecture, right? So drugs with PEG or polyethylene glycol groups are readily pumped out by those G-glycoprotein efflux transporters, so making them less likely to cross the blood-brain barrier. Okay, what else do I want to talk about? Right, this drug, alvimapan, is only used in specialized conditions such as post-operative ileus, and you are unlikely to ever come across it in a community setting. It is covered by a restricted drug access program, and only certain health professionals at certain healthcare facilities may use it. So we're not going to talk about this too much, but it's just there for your information that this is also a Pamora. Okay, so let's talk about some of the adverse effects. You will see that abdominal pain is a recurring concept or recurring theme when we talk about agents, especially prokinetic agents, because if you can think about agents increasing or inducing or that contractility or that peristaltic activity, you can think that if this is overdone or just, if it is being increased, you're likely to get that abnormal pain because you're increasing that contractility. Okay, diarrhea, yes, right. You're treating constipation. If you overdo it, this will result in diarrhea. All right. What else? Right. Now, what else do I want to cover on this slide? And as you can, like I said, the abdominal pain and diarrhea are common. A common theme across these Pamoras. Okay, some warnings. All right, so there's once again a lot on this slide. Now, I know I told you that these things don't cross the blood-brain barrier, okay? So, one important contraindication I have discussed today, or I will discuss today, is why they should not be administered to patients with a known or suspected gastrointestinal obstruction, right? This is very important, and likely Dr. Joyner will cover it. But if you think about it, if you think about a narrow tube, such as the intestine, which is obstructed, so if you've got a narrow tube and you've got a bolus stuck in there, so there's an obstruction, and you're increasing peristaltic activity, right? If it's stuck there and you're kind of squeezing it, this can result in that obstruction to kind of squeeze down and basically damage that area. So you can get this local ischemia, right? Which can in turn lead to, so if you've got ischemia in that area, blood's not coming in, you can get kind of local necrosis, right? So cells in that area will die. And then once cells are dead, you don't have, I suppose, innervation in that area, and it can actually lead to perforation, right? You can get the intestine or the colon in that area rupturing or breaking. So this is very important. If your patient has gastrointestinal obstruction, these drugs should not be used. Okay. Now, like I said, while these medications are designed not to enter the brain, it is possible that they may, and if they do, they may result in analgesic failure and or opioid withdrawal, right? Now, you will discuss opioid withdrawal later on when you talk about opioids, but think about it as an antagonist, right? It's like almost giving someone codeine and naloxone. It's not going to work, okay? You're kind of, if someone is on codeine and you're kind of stopping it, it's going to make things worse. Okay, what else did I want to say? Sorry, I'm referring to my notes to make sure that I'm telling you everything you need to know. So excuse me while I kind of refer to my notes. Okay, so methyl naltrexone. So this largely stays in the GI tract. So things like drug-drug interactions are not much of an issue. But for nalmefene and naloxegol, there are a few drug-drug interactions to consider. Now, I talked about P-glycoprotein inhibitors, and this mostly applies to nalmefene. But for CYP3A4 inhibitors and inducers, it is important to modify dose. Okay, so this is the point I'm talking about over here. So strong inhibitors, so normally increase metabolism and therefore increase plasma concentration of those two Pamoras, whereas strong inducers increase metabolism and reduce plasma concentration of the pomoras, right? And I provided specific examples on the slides for these cases specifically. So we've got strong CYP3A inducers such as rifampin, which will decrease these concentrations, will decrease plasma concentration of these two agents, and therefore they should be avoided. Okay, so we've got some contraindications, warnings, drug-drug interactions. Okay, let's move on to our next group or set of drugs, prokinetic agents. Okay, so our third category, let's briefly talk about prucalopride and tegaserod. Both of these drugs act as agonists of the serotonin 5-HT4 receptors. And similar to other drugs we have discussed, they're increasing that peristaltic activity in the GI tract, right? You've got constipation, you're trying to kind of improve that motility. All right, so adverse effects, as noted over here, the most common, we've already talked about abdominal pain, we've already talked about diarrhea, and you will note that headache, nausea, and vomiting is another common theme with these drugs. And as you will appreciate, you've been in pharmacy school for a while, nausea, vomiting, and headache is kind of listed on most leaflets for most drugs as an adverse effect. Okay. Precautions. So for both drugs, suicidal ideation and related behaviors, especially in patients with existing depression, should be monitored. Right now, remember serotonin, remember brain, right? We are dealing with drugs agonizing the serotonin system. So while these drugs are designed not to cross the blood-brain barrier, any spillover into the central nervous system could affect that serotonergic system. All right. And lastly, specifically for tegaserod, we have a specific warning, right? So there have been reports of increased risk of ischemic events such as stroke, heart attack, and then eventually death. So like for any medication, for this medication, you would need to consider the risks of treatment with associated treatment benefits. If your patient has recently had a MI or they are actively taking a certain cardiovascular medication, you'd want to consider the benefits and risks. Okay, so contraindications, similar to the pomoras we discussed earlier, you will notice similar contraindication exists for the 5-HT4 agonists for similar reasons I outlined before. And not surprisingly, as I discussed, tegaserod should not be administered to patients with a history of MI, right? Because it increases the risk of this or increases the risk of a secondary event. Okay, so we've talked about these prokinetic agents, right? Now let's talk about laxatives. Okay, so as you will see in my slides, I will talk about kind of an overall grouping, and each of those groupings will have kind of subgroupings sometimes. Okay, so laxatives, which you will all have heard of, can work by increasing motility or doing so indirectly, making it easier by increasing the fluid content of stool. Okay, so to date we've talked about prokinetic agents, which just affect the motility. Now we're going to add in that these agents can affect both motility and the wetness, so to speak, right? So based on the mechanism of action, laxatives can be divided into these four groups. Right, here are your four groups. And on the slide I've listed the major mechanism of actions for each of these. So promoting or increasing the amount of fluid to be retained within the gut wall, or like I mentioned earlier, increasing that motility or that force of contraction, right? Some laxatives may have more than one. Okay. And yes, I think I've said everything else. Let's go on to the next slide. All right, so first group or subgrouping is the bulk forming agents. And like the name suggests, these agents promote peristaltic activity by having the property of being poorly digested. And what happens is if these agents hang around in the gut or the colon, they actually increase the amount of water which is reabsorbed or which stays in the colon. So together these effects, right, so them being poorly digested results in, as the name suggests, increasing the bulk of the stool. And some of you are thinking, hey, this is kind of counterproductive, right? If someone has constipation, why would you want to do that? Why would you want to increase the bulk of the stool? And you're thinking, hey, this is counterproductive. But these agents help to what we call distend the colon, right? So because they're poorly digested fibers, what happens is you get this gel-like substance being secreted, and the combination of excess water actually promote peristaltic activity, right? And as stated on the slide, one side effect can be bloating due to the absorption of excessive water, right? And flatus, which is just gas, right? So we cannot, or our gut, we cannot digest these fibers, but our gut has bacteria which try to break down the fibers, and some of them do it successfully, and then the byproduct is unfortunately gas or flatus. Okay, so what else did I want to say? Oh yes, so bran and psyllium husk are notorious for increasing gas, whereas methylcellulose and polycarbophil to a lesser extent. So if someone does not want those, excessive flatulence side effects, you could think about these two agents instead. Okay. Our next category are stool wetting agents. And like I said, some of these kind of names kind of give the mechanism of action or how they work away. So we got docosate and we've got mineral oil. Docosate allows or increases the amount of lipids and water to penetrate the stool or the bolus within in your gut. This makes it softer, which then makes, peristaltic easier. So you're kind of relieving that constipation. The second agent, mineral oil, once again, helps to soften the stool, and this helps with the constipation, so makes it easier for the stool to pass along. You can see there's no kind of side effects which have been listed here. It is rare for these agents to induce side effects, but as you're all thinking, overuse or incorrect use can have the effect of increased bowel movements or resulting in diarrhea. So we obviously have to dose appropriately. Okay, osmotic laxatives. Now, as you can see, these are broken down into three broad groups. We've got your polyethylene glycol. I mentioned this group earlier. I mentioned we talk about them later. We've got saline laxatives, and you've got various kind of saline salts. And then we've got the non-absorbable sugar laxatives. All right, so polyethylene glycol, or PEGs, as they are most commonly abbreviated to, So this grouping here, H, this chemical formula here is your ethylene glycol, and then when you put these brackets and you put an N, that's where the poly comes from, right? And if you look into certain preparations, you might actually see a PEG followed by a number. This indicates the amount of poly, right? How many ethylene glycols you have. Okay, so what else do I want to say? Okay, so like it says on the slide, this normally comes either in an electrolyte solution, and I'll tell you why soon, or in a powder form, which is suggested you put into an electrolyte solution. Okay. So like I said, if you ever come across these pegs, they will normally have a number next to it. So peg 3500, peg 4000, and this outlines a number of ethylene glycols in it. So pegs are poorly absorbed from the GI tract and result in increased water retention, right? The body in turn, right, to maintain osmotic balance, right, will often pump electrolytes into the gut, right? Because you've got too much water in your gut, right, your body, to maintain homeostasis or maintain osmotic balance, will pump electrolytes in it, right? This is not a good thing, right? And this will result in osmotic imbalance, right? So this is the reason why it is always either the PEG osmotic laxative come either in an electrolyte solution, or the PEG powder you need to dissolve in an electrolyte solution, because you don't want that, you don't want excessive electrolytes moving into your gut, which causes an osmotic imbalance, which then will have other adverse effects such as cramping and dehydration specifically. All right. Okay, and the final thing which I wanted to talk about is catharsis, or pharmacological catharsis, which is a complete emptying of the stomach and intestine and the colon, and is often used for procedures such as endoscopy, right? Or if they're putting, if you're going to have some kind of GI procedure and they need it to be absolutely empty because they want to have a look around, what will normally happen is they will give you a large quantity of PEG to drink, but it will be like a large quantity to drink over small amounts over a period of time. And this will help in kind of completely evacuating or emptying your bowel in your GI tract. And as you'll note from the osmotic laxative, these are commonly used for this purpose. Okay, so our next group, the saline laxatives, you can see we have 4 main ones, 3 derivatives of magnesium and 1 of sodium. All right, and so these work in a somewhat of a similar mechanism to PEGs. Saline laxatives are poorly absorbed from the GI tract, so working on this osmotic balance issue, right? Saline laxatives are poorly absorbed, so you get increased water retention within the gut, which helps with constipation by encouraging peristaltic activity. More water, easier to move the bolus of the food along, right? So similar to PEGs, these can also be used when you need to have a pharmacologic catharsis, right? And obviously it depends on the volume and route of administration as noted. Excuse me, I don't know why I keep doing that. Okay, so with respect to adverse effects, I mentioned cramping and dehydration in the previous slide, so for PEGs, and as noted on the slide, it's important to consider patients with renal dysfunction, or watch out for patients developing hypermagnesemia or hypernatremia. Basically, because you're messing with the amount of water and the kind of osmotic balance in your gut, this can have kind of downstream effects on your renal system. So it's important to monitor, especially in patients with decreased renal function. Okay, so our next category, or final category, I think in this, is a non-absorbable sugar laxative. So we got 2, lactulose and sorbitol. Once again, similar to PEGs and osmotic laxatives we have discussed previously, poorly absorbed from the GI tract and cause a retention of water osmotically, which in turn encourages that peristaltic activity, and your constipation hopefully goes away. So these 2 compounds are not as strong as PEGs or saline laxatives, and therefore they are not used for catharsis. Okay. What else did I want to say? So constipation, once again, side effects, abdominal discomfort, once again, just from that motion or increased peristaltic activity, and flatulence. So once again, the bacteria. So it's not you, it's the bacteria. Blame the bacteria. Are trying to break down both of these, which are poorly absorbed, right? They're poorly absorbed, and the bacteria are trying to break it down, and often it increases the amount of flatulence or gas. Okay. Oh, we got one more. Stimulant laxatives. Okay, so let's move away from, I suppose, osmotic laxatives, right, and quickly discuss these two. So we've got the anthraquinone derivatives and the bisphenolmethane derivatives. So we've got Senna and we got Biscodyl, which I won't say something you've used before, but yeah, something I'm sure you've heard about, especially if you've been in a pharmacy. Okay. All right, so Senna is not, the mechanism of action is not actually clearly understood in humans. Now, I've put this in purple. This is not something which you need to remember, or it's unlikely that this will ever be, examinable. But it's just if you were interested to understand how Senna works. This is in rats. So you've got Senna, which consists of two components, senescide A and senescide B. The senescide A is metabolized by gut bacteria to some kind of metabolite, right? There's a metabolite, which eventually results in decreased aquaporin 3 expression, decreasing water reabsorption, increasing fecal water content, and there you go, right? That is what is relieving your constipation. So if you're looking for a mechanism of action to understand how Senna works, there it is. But I will say that this was not examinable, and like I said, it's poorly understood. So don't overstress on the mechanism of action for this one. All right. This is something which Dr. Joyner will probably discuss with you as well, but with respect to adverse effects, as we have noted in agents with increased peristaltic activity, abdominal discomfort and cramps is common. And like I said, if too much of a good thing, in this case, will result in diarrhea. Okay. Now, it is generally not advisable to use Senna-containing products for more than 2 weeks, as it may cause dependence on laxatives. So patients will require this to defecate even after their constipation has been resolved. Furthermore, Senna containing products can irritate the cells which line the lumen of the colon, okay, which eventually results in apoptosis, and then this results in this pigment being released, which basically dyes the colon. Now, in this patient, they had been taking Senna, and they had an endoscopy, I suppose, procedure, and they noted this kind of dark pigmentation. Right now, while this looks like, hey, this is something serious, this might be cancer, but it is totally benign. It's just a discoloration, and the same patient. I think this is 6 months later. My notes say 6 months later, you can see the discoloration has stopped, right? Now, 6 months is a long time. This can also happen in the mouth, so you have to be careful. And I mentioned this because, a patient might come to you when you're in a pharmacy and say, hey, I've got this note from my, endoscopy procedure. It says I've got melanosis coli. Right, and just for that purpose, you will know what it is, and you'll be able to tell the patients, hey, this is benign, it's not cancer, this is what you need to do to revert it. Just stop the Senna. Okay, so our last laxative, Biscodyl, and there's a trade name, and there's many trade names, as we know, for this. Once again, the mechanism of action is poorly understood. right? But for our purposes, we will say that it stimulates peristaltic activity, and as you will note a theme, it inhibits water reabsorption, right, in the colon. So we're getting more water being retained, we're stimulating peristaltic activity, you are helping with the constipation. Okay. So because this drug retains water in the colon, it has that possible side effect of dehydration and electrolyte imbalance. So like we discussed for the osmotic laxative. For this reason, once again, it is recommended that you only use it short term. So that's no longer than a week, so no longer than 7 days. And like Senna, there is a risk of developing dependence on laxatives. Yeah, who knew you can get dependence on laxatives as well. So yeah, definitely do not take or advise to take for longer than 7 days. What else did I want to say? Right. Lastly, this drug can be used in conjunction with polyethylene glycol for complete colon emptying. So for that catharsis. Okay. And I've already mentioned the dehydration. And so once again, be careful in patients who have some kind of renal dysfunction, as you can get, keep doing that, some kind of imbalance in your potassium or your other kind of salts. Okay, and I mentioned just dependence on laxatives, so do not use for more than 7 days. Okay, excuse me. Okay, antidiarrheal agents. Okay, so we're going to flip the table a bit. Excuse me. So far in today's lecture, we've talked about constipation by promoting that peristaltic activity. And you've noted that a lot of the drugs for constipation, the side effect is diarrhea, which when defined is often a result of that osmotic imbalance leading to insufficient water reabsorption, or too much peristaltic activity, or a combination of both. Okay. So now we're going to talk about agents used for the treatment of diarrhea, so anti-diarrheal agents, right? So we will talk about drugs used basically to do the opposite of constipation drugs, right? We will also talk about how anti-diarrheal agents can be used to manage conditions such as irritable bowel syndrome or IBS. Okay. And finally, as I mentioned before, you will cover this or the therapeutics of these agents in detail with Dr. Joyner on Monday. Excuse me. All right. So we will discuss these three main groups: opioid agonists, right, colloidal bismuth compounds, and bile salt binding resins. All right. Let's get started. Loperamide Imodium. Once again, I'm not going to say we've all used it, but it is one of those common drugs which you come across. Like the most common is loperamide, and this is an opioid agonist. Other opioid agonists include diphenoxylate, diphenoxin, and eloxadoline. All right. These agents are designed, once again, to bind to peripheral opioid receptors, right? And now think about it, these are opioid agonists, so we don't want them crossing the blood-brain barrier, right? So these agents are designed, and once again, they've got specific chemical moieties attached to them, which make them either a positive charge, which we talked about. We've got basically they get kicked out by the P-glycoprotein receptor, right? So all of these agents are designed not to cross the blood-brain barrier, to hang around in the gastrointestinal system, to cause the anti-diarrheal effect in this specific case. Okay. What else? So as stated on the slide, loperamide and diphenoxin largely act through the mu opioid receptor, where eloxadoline, and I will talk about it, has a mixed action. And we'll talk about what that mixed action is. Okay, so the overall mechanism of action, which you need to remember or need to understand, is a result. What these agents do by binding to the mu-opioid receptor is overall result in decrease, right? We're reducing acetylcholine release on those smooth muscle cells, right? Think myenteric plexus, think circular and longitudinal muscle. We're decreasing peristaltic activity, right? We're talking about diarrhea now, so we want to reduce or decrease peristalsis. So this, in combination with increased water reabsorption, right? So we're increasing the amount of water being removed from the gut. This helps to both reduce the frequency as well as the fluidity of bowel motions, right? And that's what we want, and that's how we're going to stop diarrhea. Okay, as promised, a bit of a closer look at this drug, elaxidolene. This drug is an agonist, right, at the mu-opioid receptor, but it is an antagonist at the delta opioid receptor. All right. So I'm going to say this again. It is an agonist at the mu-opioid receptor and an antagonist at the delta opioid receptor. Now, it is important to remember that the main mechanism of action is still via the mu. This is the main mechanism of action which you need to remember. But one of those, I suppose, special things about this drug, it's got that dual action. And why? Why does it have that dual action? Okay, so by antagonizing this delta receptor, this blocks the endogenous ligands, right? So the endogenous ligand for the delta opioid receptor are things referred to as enkephalins. Right? And once again, you will discuss this in more detail when you talk about opioids. So when enkephalins are blocked from binding, this increases secretions, right? And now you're going, hang on, why are we increasing secretions? This is counterproductive, especially if someone has diarrhea. Well, considering we're trying to reduce fluidity, right? How is this going to work? All right, I'll tell you how. In this slide. All right. So elaxidolene is predominantly used for diarrhea in inflammatory bowel. Right. So you would think that this is a relatively long-term use, whereas other drugs such as loperamide and diphenoxin are recommended to use short-term or for things like traveler's diarrhea. Right. But think about, we've already talked about drugs used in constipation, right? And we said if you use them incorrectly or use them long term, you might get diarrhea. The same thing with, or the opposite thing with these antidiarrheal agents, right? If you use them long term, you may eventually get constipation, right? So that is the reason. Now think about the constant activation of these mu-opioid receptors. Like I said, if you are constantly activating these in the gut, you may eventually or likely to get constipation. Therefore, by having this dual action of elaxidolene of being an agonist as well as antagonist. Now remember, the antagonist increases the fluids. Right? So if you're using it long term, right, you're still having that opioid agonist activity, but in the background you also have this activity of increasing the amount of fluid. So you kind of get this balance happening. So like I said, it's for treatment for irritable bowel syndrome or for long-term use. And it balances so you don't get constipation. What else should we talk about? All right. So once again, with anything which is opioid, which is an agonist, right, at standard doses, these drugs do not, or they're not supposed to cross the blood-brain barrier, right? And as the slide states, loperamide is a substrate for that PGP, right? P-glycoprotein receptor, so it is actively stopped from doing so, right? The P-glycoprotein receptor will say, hey, no, you're not allowed into the blood-brain barrier, out you go, right? Now, all these agents at higher doses, right? Now, if you think about receptor saturation, right? If you take too much of loperamide, you're likely to saturate the PGP efflux transporter, and some of the loperamide might escape that and go into the blood-brain barrier and into the central nervous system at a higher dose, right? So at higher doses, a lot of these drugs may spill over into the CNS, and being an opioid agonist, you might get this kind of mild high or euphoria. And there are actually some reports of drug abuse from loperamide and diphenoxin, right? Some of you are rightfully thinking, who would want to do this? And I will already tell you, you cannot crush these pills and inject them. It doesn't work, right? It is actually taking a lot of these tablets. Not the best way to get a high, but hey, it is noted that people or some individuals have tried this. Okay, what else do I want to mention? Diphenoxin, right, which is a metabolite of diphenoxylate. Oh, I should have told you that. My apologies. All right, so diphenoxylate over here and diphenoxin. So diphenoxylate is broken down to diphenoxin. All right, that's what I forgot to mention. Now you know. All right. So where are we? Diphenoxylate and diphenoxin. All right. So atropine. That's the other thing I wanted to mention. Okay. Well, like I said, I want to make sure that I get everything across that you need to know. So I'm just referring to my notes. Okay. So diphenoxin, which is, like I said, one of the metabolites or of diphenoxylate. Can also cross the blood-brain barrier, and like I said, at low doses, it's not really going to do much, right? And if you look at the doses of diphenoxin and diphenoxylate, it's normally 1 to 2 milligrams, okay? And so if you take 10 or 12 or 20 of these tablets, you might get this mild euphoria or kind of a high, but yeah, it's I don't know. It doesn't seem like, to me, the best way to try and get a high. Okay. All right. So in addition, so kind of to avoid people or to deter people or discourage, like it says on the slide, from trying to abuse these drugs to get a high, they put a bit of atropine in it. And when I mean a bit, I mean like 0.025 milligrams, right? So often if you quickly look up, if you ever seen diphenoxin or diphenoxylate, you will see it's got diphenoxin/atropine, and it will state the dose. So if you remember to your basic pharmacology, atropine will induce effects such as dry mouth, blurred vision, urinary retention, tachycardia, and I know even the seasoned drug abuser doesn't want to experience those effects, right? So while the abuse potential is low, these drugs are still placed on Schedule 4 and 5 of the controlled drug list. So yeah, it's important to know. Okay. So adverse effects. Constipation, right? We've been talking about drugs used for constipation. The adverse effect was diarrhea. Now we're talking about drugs used to help or treat diarrhea, and we've got adverse effect constipation. Right. So for loperamide, a warning at high doses is also for torsade de pointes, or it's a type of ventricular arrhythmia where your heart is not beating in the way it should beat. So it's not going boom boom, it's going boom 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 boom, whatever way you want. It's not beating the way it should, and that is a specific adverse effect for loperamide. So like I said, if you've got a patient who has some kind of cardiac condition or some kind of arrhythmia, you would not want to prescribe them loperamide. You'd want to think about a different drug. Okay, so for different diphenoxin, similar, we've got constipation, which can be an adverse effect. And of course, we discussed the very low dose atropine, so you can have those anticholinergic effects, which I talked about. And also both for loperamide and diphenoxin. Ileus. What is ileus? Ileus is the inability of the intestines to move material through it normally. So it's kind of like a severe obstruction. It can result in an obstruction. What we got? Warnings. All right. So due to the risk, right? We're talking about opioid agonists, right? Now I've said these are very low doses, okay? But due to the risk of these agents, they can cause respiratory and or CNS depression. So the use of these agents is contraindicated in pediatric patients. And I'm sure Dr. Joyner will talk about this in greater detail. And you will talk about how respiratory and CNS depression occurs when you talk about opioids. I think that's in a few weeks. Excuse me. What else? Okay, so it's also known these medications should not be used in patients with certain bacterial infections. So the point being that it is recommended that the bacteria be removed, right? So if you've got diarrhea, you do not want to stop the diarrhea. If there's a specific bacteria in your gut which has caused that diarrhea, it's kind of better to get that out of your system, right? I mean, yes, there's risk of dehydration and all that stuff, but if it has been identified that you have a specific type of infectious diarrhea, it is not recommended to take these agents, as kind of stopping it leads to this bacteria hanging around in the gut, which may then cause some kind of infection in your GI tract and eventually leading to sepsis, which, as you know, can be life-threatening. And then, of course, related to the, I suppose, diarrhea in some kind of in some patients, this is more about counseling, right? If you've given your patient one of these medications to manage their diarrhea, they may think to themselves, hey, I don't need to drink water or I don't need to rehydrate, I don't need to watch my electrolyte. So while this is not, I suppose, directly related to these drugs, right, you still want to counsel your patients like, yes, you've taken this medication to stop your diarrhea, but you still need to make sure you keep up with your fluids, rehydrate, have some Gatorade, whatever is appropriate. Okay, drug-drug interactions. We've talked about opioid agonists being respiratory and or CNS depressants. Okay, so it is advisable to avoid any other CNS or respiratory depressant. So things like alcohol, benzodiazepines, which are known, right, to either, like I said, CNS depressant, or benzodiazepine also CNS depressant, right? You don't want to add on or potentiate the effects of these agents. Okay. What else? Loperamide, right? So for loperamide, CYP3A inhibitors, such as cimetidine, or inhibitors of the P-glycoprotein receptor, they can increase the plasma concentration of loperamide, which then can, increase the risk of these adverse effects. And once again, watch out for ventricular arrhythmias. Okay, so you have to watch out for that. All right, I think, yes, that is all I wanted to say on this slide. Okay, adverse effects continued. Specifically, we have adverse effects for loxadoline. All right, so specific specific warnings or specific adverse effect include pancreatitis and severe constipation, which has sometimes required hospitalization. And you will note that the contraindications are related to the adverse effects and warnings, right? So all of these contraindications are related to pancreatitis. All right. I think that's all I wanted to say about opioid agonists. Yes. Just looking at my notes to make sure. Okay. Okay, so let's move on to our next kind of grouping of antidiarrheal agents. So you've got your colloidal bismuth compounds. Most famously, I suppose, or most commonly known as Pepto-Bismol and other drugs. So where are we? So bismuth subsalicylate or salicylate, however you want to pronounce it. So this drug, when it comes in contact with the acid, so with the acid in your gut, it breaks down into bismuth and salicylic acid, right? Or salicylate. So the salicylate part of it increases water absorption, right? So when you're increasing the amount of water from your colon or from your gut, this is going to help with the diarrhea, especially the fluidity of your diarrhea. Okay, so in addition, the salicylic acid or the salicylate, as you will know, by being an inhibitor of COX, this acts as an inflammatory agent, right? So, and this is a good thing, as this assists to reduce inflammation, which can in itself help with reabsorption of water. Furthermore, the antimicrobial effects of this drug make it recommended for travelers, right? So you've kind of got a double whammy of the salicylate or the salicylic acid helping with both inflammation as well as helping with water reabsorption. Okay, there you go. Travelers treatment of travelers' diarrhea, and then at the same time helping with kind of that mild gastroenteritis or inflammation. Okay, our next group of antidiarrheal agents is bile salt binding resins. So bile salt binding resins such as cholestyramine, cholesterol, and cholesterol. How do these work? So let's talk about normal conditions, right? So normally bile acids are produced in your liver, they're stored in your gallbladder, and they're released into the intestine to help with digestion and absorption of fats. Okay, you might have heard of this in reference or in related to reducing blood cholesterol or blood lipids. Okay, we're going to talk about it in relation to being an antidiarrheal agent. Okay, so like I said, they're released into the intestine to help with digestion and absorption of fats. So after performing their role, so after these bile acids have done their role, most of these acids are reabsorbed in the ileum, which is that last part of your small intestine. They're reabsorbed and they go back to the liver. Okay, but in certain conditions, such as bile acid malabsorption, gallbladder surgery, right, excess or too much of these bile acids may reach the colon, which in turn stimulates water and electrolyte secretion. So you get too much, right? And this, as you can imagine, leads to stool or diarrhea. So as the excess bile acids disrupt normal water absorption in the colon, okay, you got too much. So you're getting too much water and you're going to get diarrhea. Okay, so now this is where bile acid or bile salt binding resins come in. These will, like the name suggests, these will bind your bile acids. All right, so what I was talking about in normal conditions, these bile salt binding resins bind the endogenously produced bile acids. Okay, and what it does is drugs such as cholestyramine, they prevent the absorption and subsequent re-entry into the colon. All right, what it does is it sequesters them. It kind of captures the bile acids, right, and they bind to these bile acids in the intestine, and they basically stop that normal process that I was talking about. So this will decrease the amount of bile acids in the colon, so it will reduce the amount of water being secreted, to reduce the amount of electrolytes in the colon, and thus it will help to firm up, so basically reduce the fluidity of the stool and therefore reduce diarrhea. All right, so the adverse effects, nature of these agents, they decrease absorption of some other drugs, okay? So the way they work is, like I said, they're kind of binding or sequestering, right, certain bile acids, and they can do this, unfortunately, to some other drugs. Some of these other drugs are very important. Drugs such as warfarin, digoxin, excuse me, levothyroxine, oral contraceptives, right? All of these, especially warfarin, digoxin, and levothyroxine, they have kind of narrow therapeutic indexes. So you have to be mindful if you're giving a patient cholestyramine, as well as it will impact the efficacy of these other drugs. But it does interact with, like I said, decreased absorption of many other drugs, such as statins, diuretics, beta blockers. But obviously some of the most important ones are warfarin, digoxin, levothyroxine, oral contraceptives. So just be mindful of that. Okay, IBS. All right, so I'm not going to go over this in great detail. This is just for your information. What I'd like to say is, just read this in your own time. Dr. Joyner will cover this in greater detail. What I am going to focus on is some of the drugs used to help some of the symptoms for this condition. Okay. All right, so we've covered constipation, we've covered diarrhea, right? We've talked about several of these agents already. So agents used to manage abdominal pain, where are we? Such as that, I will cover in the next few slides. But for constipation and diarrhea, we've mostly covered most of these agents. Okay. Yes, so let's get into it. Okay, so abdominal pain, this we haven't kind of covered in this, So we haven't really covered abdominal pain. We know a lot of the drugs we've talked today, especially the prokinetic agents, may cause abdominal pain. But I suppose this is in a different context. We're not talking about inflammatory bowel syndrome, which is unfortunately a chronic long-term condition. So you need something to manage that abdominal pain. Okay, so we are going to talk about tricyclic antidepressants, which are often used at low doses. Some of you are thinking antidepressants. Why would an antidepressant be used to treat abdominal pain? All right. Let's talk about it. Okay, so what I've got in my notes. So you go to tricyclic antidepressants, or TCAs, as they are commonly abbreviated to. They are often used for treatment of pain associated with inflammatory bowel syndrome, and due to their ability to modulate pain perception and gut motility. All right, let's not forget gut motility. Excuse me, let me have some water. All right, so one of the key features of IBS is what we call visceral hypersensitivity. This refers to increased sensitivity to pain or discomfort from your internal organs, especially the GI tract. Okay, so this hypersensitivity means that normal activities, right? So just your normal peristaltic activity, you get this feeling of pain, right? Just your normal peristaltic activity. So we haven't got constipation, we haven't got diarrhea, just your normal peristaltic activities, you got this kind of hyper pain threshold, so to speak, or lowered pain threshold. So like I said, TCAs work by inhibiting or by kind of reducing this, right? So they work, the mechanism of action, They work by inhibiting the reuptake of serotonin and norepinephrine involved in modulating these pain signaling pathways, right? So let me go over that. So TCAs work by inhibiting serotonin, the reuptake of serotonin and norepinephrine, right? And this helps with that exaggerated response to visceral stimuli I was talking, right? Just regular peristalsis, patients with IBS kind of feel that as increased or painful activity. Okay, so additionally, TCAs have anticholinergic effects, like I've already said, right? Well, I mentioned that before. Oops. And that's basically slow down that peristaltic activity, as I mentioned. So this can help in reducing symptoms like diarrhea. Okay, so IBS-T. So if we go back over here, you can see that you have IBS-C, so inflammatory bowel syndrome with constipation, or inflammatory bowel syndrome with diarrhea. And often you will have different drugs used to manage both of these conditions. Okay. So tricyclic antidepressants, some of you already may know, this is actually used in some patients just to help with sleep. And it is often kind of beneficial for patients with IBS to be given this because it has these multiple effects. It has that effect to reduce that pain, abdominal pain they're feeling. It helps with the slowing down of peristaltic activity, which can then also help with that abdominal pain, and also being the tricyclic antidepressants and acting at a low dose in the CNS, it can help with sleep, right? So it's got this kind of triple whammy almost. And just want to kind of emphasize that for IBS and for abdominal pain, it is used at much lower doses than what would be used to treat depression. Okay. All right. So let's keep talking about abdominal pain and talking about these other two drugs. So these are antispasmodic agents, right? So we've got diclomine and histamine are commonly used in treatment of IBS to relieve GI spasms. All right. Excuse me. Both drugs are competitive, reversible antagonists of the muscarinic acetylcholine receptors. Okay, so let's go through the pharmacology again, right? Both of these agents are competitive but reversible antagonists. And where do they act? At the muscarinic acetylcholine receptors. Okay. Both drugs are competitive, right? So they block acetylcholine's binding to these receptors in the gastrointestinal smooth muscle. Okay, so think all the way back to the beginning. You got your myenteric plexus, you got your circular muscle, and your longitudinal muscle. That's where these drugs are acting. Right? So this action specifically decreases smooth muscle contraction and reduces painful spasms, which are often associated with IBS. All right. So dicyclomine also has a direct relaxant effect on gastrointestinal muscles but once again, that exact mechanism is kind of fuzzy, it's not known. Okay. What else do I want to tell you? Okay, adverse effects. So common adverse effects as stated. So these are a result from that anticholinergic activity, right? So think atropine, right? Even though there's no atropine in here, but you have this anticholinergic activity, right? So you get your blurred vision, dry mouth, nausea, urinary retention. Those are the most common anticholinergic effects. Caution. All right, so caution is needed in patients with glaucoma. Why? So anticholinergic agents may interfere with glaucoma treatment and increase intraocular pressure. So these agents can also affect the gastrointestinal absorption of other drugs. So and I've already mentioned one for glaucoma. So if you've got a case where there's polypharmacy happening, there's other drugs being taken to manage IBS or some other medical condition, it is important to kind of take that into consideration. Okay. It's advancing on its own now. Excellent. Okay. So let's talk about the next drug, allosterone. My pronunciation of drugs. You can email me back and try and tell me how to pronounce this correctly. So I'm going to say allosterone or allocitron. Maybe that's how you say it. You can email me and tell me how it is. Or if you meet me in the corridor, tell me how to say it properly. All right, allocitron, mechanism of action, it's interacting with that 5-HT3 receptor and it's antagonizing it. Okay, so those 5-HT3 receptors are expressed on the extrinsic sensory neurons, and these transmit signals from the gut to the spinal cord. All right, so it's how your gut is telling your brain that I'm in pain. All right, so by blocking that, you're helping with abdominal pain. All right, so let's go over that again. The 5-HT receptors, which are expressed on the extrinsic neurons, and these transmit signals from the gut to your spinal cord, which then tells your brain, hey, I've got pain. So if you block them, it helps with the pain. Okay, and what else do I want to say? Therapeutic uses. Dr. Joyner will cover this in detail. Okay, one more thing I want to say. It decreases colonic motility and gastrointestinal secretions. All right, we've talked about this, right? If you're reducing motility and you're reducing secretions, what is it helping with? So that would be your IBS type D, right? So if you've got IBS with symptoms of diarrhea, this drug will be helpful there. Okay, like it says, allosterone or aldosterone, it's specifically approved for use in women with severe IBS-D who have had chronic symptoms. Okay, who have chronic symptoms lasting 6 months and longer and have not responded to conventional therapy. All right, and here we got more specific serious warnings and gastrointestinal adverse reactions over there. But the most important one to remember is this is only for, or approved, this drug is only approved for women with severe IBS-D. Okay, so we've discussed MOA, we've discussed where it's used, you know how it blocks pain. Excellent, let's move on. Okay, so adverse effects. It's associated with several adverse effects, unfortunately, the most common being constipation, GI discomfort, and pain. That's interesting. When you're trying to reduce abdominal pain, it might actually increase pain. Think about how that might happen. So due to the risk of severe constipation, the drug is actually contraindicated in patients who currently have a history of chronic or severe constipation. And that's because it may exacerbate these conditions, right? Been talking a lot about this. All right, so additionally, allosterone should not be used. So like I said, do not use concomitantly with fluvoxamine, which is a strong inhibitor of CYP1A2, which has a risk of basically increasing potentially serious gastrointestinal complication. So this increases concentration of allosterone, and like I said, it basically increases the risk of these adverse effects. So just be mindful of if someone is taking this drug, you'd want to reconsider prescribing or recommending allosterone. All right. Okay. I'm just going back to make sure I've told you everything I needed to tell you. Okay. So like I said, there's IBS-D and there's IBS-C. So inflammatory bowel syndrome and constipation. We're going to talk about two drugs which help in this, or help with these specific symptoms. So these agents are referred to as prosecretory, right? So that is already telling you what they're doing. They're promoting secretion. All right. So I am not even going to try and pronounce these drugs. I suck at pronouncing drug names. You can all help me when I meet you for the GERD and peptic ulcer disease lecture. I am going to get you to help me to pronounce both of these drugs. Okay, oops, let's go back. Okay, so both of these drugs are used to treat constipation, predominant irritable bowel syndrome, and chronic constipation, or chronic idiopathic. So that's when the cause is unknown. All right. Excuse me. All right. So lubiprostone is a prostaglandin E1 analog, right? So we're not talking about this drug, in case I didn't pronounce it properly. And this activates chloride channels on the gastrointestinal epithelial cells. So think back all the way to the beginning, right? Think back to the two plexi we discussed, right? Where the epithelial cells and where this kind of promotes, right? That secretion effect. So it promotes chloride secretion into the gut. And think about osmosis, right? What is this going to happen? What's going to happen if you increase if you increase the concentration of electrolytes in one thing, you're probably going to get an increase in secretion to kind of help, right? So you're going to have more water being reabsorbed, and that's going to help with the constipation. What else do I need to tell you? All right, so linaclide and plecanatide are peptide agonists for guanyl C cyclase. So now we are talking about this drug, right? So this is a slightly different mechanism of action. Where I lost my train of thought, I apologize. Okay, here we go. So these are peptide agonists. They activate CFTR channels. All right, who remembers CFTR? If you don't, go back to your early pharmacology. See if you can remember what CFTR channels are. All right, so by activating these CFTR channels, what it does is increases chloride and bicarbonate secretion, right? So what like I've already talked about, this leads to an increase in the amount of luminal fluid, so the amount of fluid within your intestine and colon, right? And like we've talked about when we talk about constipation drugs, when you increase the amount of fluid, this helps with peristaltic activity, and it helps with reducing the hardness or stiffness of any stool or any other object in your colon, and it helps with bowel movements. What else? Therapeutic uses, Dr. Joyner will discuss. Sodium and water follow chloride secretion, right? Like I said, this is increasing chloride. This is increasing electrolytes within the lumen, right? And this is via osmosis, this is causing more water to come into your gut, right? And that is what is helping with your constipation. So what else do I want to say? Okay, and I suppose another thing which I wanted to say is, I've already talked about that. So not only do the sodium and water kind of chloride help with that increase in water and increase in fluidity and peristalsis, it also happens, like I said, it also helps with softening the stools and just promoting passage, Constipation is not fun. So just help with the peristalsis and help with softening, kind of helps to relieve the constipation. So lubiprostone is approved for opioid-induced constipation. So if you think back all the way to the beginning of the lecture, we talked about opioid-induced constipation. And linaclotide and plinactide are used for both constipation or constipation predominant IBS, so IBS-C, and chronic idiopathic. So that's when you're unsure of the condition, unsure of the reason why someone has constipation. So chronic idiopathic constipation. Okay, I think I've covered everything in this slide. Okay, so some adverse effects and some contraindications. So lubiprostone, linaclotide, plinactide are all used for constipation, predominant IBS, and like I said, chronic idiopathic constipation. And some of the important adverse effects I want to cover: nausea. While you're thinking, hey, nausea is common, right? It happens with a lot of medications, or I've mentioned it a lot. This can be very severe, right? There is a specific warning that can be severe. You can also get diarrhea, once again, can be severe, and dyspnea, right? So within an hour of the first dose. So these are some of the specific adverse effects and warnings to remember. Okay, linaclotide, once again, diarrhea, severe abdominal pain, flatulence, abdominal distension. Plecanatide, while it's your common diarrhea, I suppose the main thing I'm trying to say is these drugs, while they have these kind of common or relatively what you might think are benign adverse effects, there are several warnings in each of these which say severe, severe, severe. So just be mindful of that. A critical contraindication, and we've already talked about this when we talked about drugs used to help with constipation, is do not use in patients with known or suspected obstruction, right? So all three of them. And we talked about why. So if you've got your intestine or your colon, you got something stuck in there, right? If you're squeezing it or you've got an agent squeezing it, you're going to promote, you might cause what we call local ischemia, right? Squeeze, 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 you might get that blockage, blood can't flow there, you get necrosis, right? Cells around that local area die, and then you eventually get severe sepsis or some kind of infection developing in that area, and then eventually maybe a rupture. So all of these things we don't want to happen, so just be mindful. Okay, I think I have covered most of IBS, and like I said, Dr. Joyner will cover the therapeutic side of things in greater detail. With that, like I said, my email is there. Please get in touch if I have said something which isn't clear. This is not something which I'm an expert on, but yeah, pharmacology is my thing. So here I am teaching you the pharmacology of these drugs. Okay, so by now you should all be experts in how drugs used for constipation, diarrhea, and IBS, right? I prepared a short practice quiz for everyone to have a go. After you go through this lecture, it's relatively easy. Some of the questions are taken from, I won't say practice exams, but hey, it might be. So please go over it. Get back to me if you're stuck on something or something doesn't make sense. Like I've repeatedly said, Dr. Joyner will cover the therapeutics of this section with you next week, I think on Monday. And then I will, I think in person, go over the pharmacology of drugs used in peptic ulcer and GERD specifically. Okay, so thank you for your attention. Once Once again, please get in touch if you have any questions. All right, I will stop this Panopto.